for being here. So just a couple of things. Number one, we have turned the air down. We're trying. I know it's hot. And the restrooms are all the way in the back. And so there's restrooms back there if you need anything. We're gonna set up some panel sessions, and so we'll introduce everybody. We'll do like 10-minute panels with each of the speakers, and then we'll have some question and answer sessions. And there are door prizes for question and answers. Somebody left their key. I found a key. Somebody brought me a key. That's yours. Go Tiff. Um, so we're just happy to get started. We're happy to have you all here. If you need anything, let us know. There's drinks, whatever you need. So I'm Dr. Jessica Enoch. I got pulled into this group, and it's been wonderful collaborating with everyone. In the back, I did want to point out, just to kind of allow everyone to take pictures and selfies. There's little signs back there that are healthcare oriented. The name of our group, the founding members, we're calling physicians of Oklahoma. So what does represent? Which is power. And so we would love to have everyone take pictures and get all kinds of feedback, like Dr. Sindel mentioned. So we can make this event a yearly thing and make it better. I would love for Stephanie to quickly talk about this breast health center. Okay, so this is several years in the making of coming up with a women's health center. This is specifically breast. We're a full service imaging center, so breast mammograms, ultrasounds, MRIs, contrast enhanced mammograms. We have genetic counseling and genetic testing. So there are lots of different things that I'll throw out throughout the talk. But we have different ways for you to figure out if you would qualify or need to have genetic testing to see if you have breast disorders. We were trying to make this facility an easy, fast access to people. So in the Oklahoma City area, if you have an abnormal screening mammogram, it is often weeks before you can get the rest of your workup done. And so our goal is to get people in and worked up very quickly. So and hopefully with all the resources, we have connections to oncology, but also the proton center, which is one of our big kind of joint venture people. So lots of radiation options for breast cancer patients as well. So Dr. Stidham. For everybody here to introduce themselves, I just wanted to give a shout out to Dr. Bayless, our male ally here. He has been hugely supportive of this initiative. He has this whole setup. This will be live streaming. And his brainchild is SheTVcom. He is too humble to get up here, but I did want to give him a shout out. SheTV.com. It has a lot of podcasts, women's health related podcasts. I highly encourage you guys to share it with everybody. And like I said, this will be live streamed. And now I would love for everybody, all our great speakers, these incredible women, to introduce themselves. Hi, I'm Innocent, and so I did fellowship training at OU about maybe 9 years ago. So I've been doing breast radiology for quite some time, like making sure that imaging center. I'm still connected from what I did on the city, so this is my first. And so I'll take you all the way from school, which is like all you have to do. So the medical procedures and the injury procedures, the breast procedures, and the very best resolution monitor, so I can see really. I love it. super excited that she accepted to speak to us. She is doing two talks today. So we're very excited to have her. She's an obstetrician gynecologist at Lakeside Women's Hospital here officially in Oklahoma. I'm going to be talking about screening for cervical cancer and hormonal. All right, and then we have Natasha over here. She is at our breast center as well. Um, when Dr. Taylor talks about a comprehensive solution to breast issues, she means comprehensive. Natasha does both mental health and sex therapy, and is immediately available for any sort of issues that might come up during treatment and diagnosis or any other issues that you may have. So this is Natasha Lane. Hi everyone and welcome. So good to see everyone today. Yeah, just a great introduction. What else can I say? Yes, I'm an American family therapist, licensed in Oklahoma and California, and I specialize in sex therapy. And today I'm going to tell you a little bit about what a sex therapist is and why you need one. Right, and last but certainly not least, Dr. Pranati Lehman has joined us from Spectrum Dermatology. And she'll be giving us all kinds of information about taking care of your skin and screening. Good morning. It's so wonderful to be here today. We'll talk about the three most common skin cancers and how we screen for them and how you can reduce the risk of developing skin cancer. Thank you. Okay, we're going to go ahead and get started. So we'll have our first four speakers. And so session one is colon cancer screening, breast cancer screening, skin cancer screening, and cervical cancer screening. So if you ladies want to just sit here at the table, all right, well, let's get started. Um, this session is all about screening and prevention. And my name, as you guys heard, is Pooja Singhal. I'm a gastroenterologist in the community. I've been practicing for 9 years. I trained at Georgetown, both my residency and fellowship, and I'm so thrilled to be back in Oklahoma, just serving my community. So let's get started. Colon cancer. Give me 1 second. All right, why do we care? Why do we care about colon cancer? Can anybody tell me what these blue flags at the National Capitol in DC stand for? This was a display in Washington, D.C. in March 2024, United in Blue. Anybody have any idea? Pardon me? Close, close. Because you answered, I have a little prize for you. This is that kind of talk. Thank you, Jessica. These flags represent 27,400 estimated colorectal cancer diagnoses by 2030 between ages 20 and 49. How many of us have thought that the age of colon cancer screening is 50 for decades, right? And I just want to start by pointing out the attention here. We are seeing this disease in younger and younger people. All right? So my goal today is to talk about how common colorectal cancer is. What is it and why should I care? What causes it? And how can it be prevented? And more importantly, what can you do to prevent it? So with that, let me ask you a question. What common cancer can you prevent with screening? And why it can be prevented, we're going to learn. Anybody can name a U.S. president who was affected by colorectal cancer and really helped improve awareness? Ronald Reagan, the 40th president. He was diagnosed in his second term with colorectal cancer. Fortunately, it was an early diagnosis. It was surgically removed, and he did well. But he was instrumental in his time to raise awareness. So throughout my slides, I'm going to point out and highlight very public figures who have been affected. So colorectal cancer affects the large intestine, which is called the colon. And it's about 5 feet long. The last 6 inches of the large intestine is the rectum. And basically, the whole reason we care about the colon is it's an instrumental organ in reabsorbing salt and water and storing it. As my mentor once said, to swallow food and defecate is a common right. It should not be a choice. So there are a lot of people who suffer from constipation, diarrhea, and the colon malformation. So what is cancer? What is colorectal cancer? It's the growth of abnormal cells that invade the normal tissue and then can spread into the colorectal cancer is the second leading cancer killer in USA. True or false? Remember, I have prizes. True, yes. So it's the third most common cancer in both men and women combined. It's the second most common cancer that leads to death in the United States. Very, very important. And that's why we're talking about it. More than 50% of colorectal cancer can be prevented. And the lifetime risk, 1 in 25 women and 1 in 22 women, men have a lifetime risk of colorectal. There are more than 25 people in this room today. Chadwick Boseman, another very popular public figure who unfortunately died of colon cancer at age 43. He had stage 4 cancer that he struggled with. Colorectal cancer often starts with no symptoms. True or false? Yep, very good. But I didn't see two answers fast though. So I'll just have to pick randomly. Yeah, let's talk. Yeah, yeah. So this is the most common misconception that I hear from my patients when I'm trying to convince them about disease. They're like, "Hey, I don't really have symptoms. I don't have a family history." Well, the one risk factor that we all have is age. We're all right there, independent, age is an independent risk. All of us have a risk of it. And if I want you to take away one thing from this lecture, you don't have to have family history, you don't have to have symptoms. All of us, just like we do maintenance on our cars, this is what we need to do for our own health. More than half of the people diagnosed with colorectal cancer have no symptoms. And what are these symptoms? I have a picture here. I have an extra picture. Blood in stool, change in shape of stool, abdominal cramping and discomfort, prolonged constipation or diarrhea, decrease in appetite, unintended weight loss. So if you're having any of those symptoms, please do seek care. That's first and foremost. And if you're 45 or older, you should you should talk to your provider about getting colon cancer. So as I mentioned, what are the risk factors? Age, independent risk factor, family history, genetics. So if you have family history of colorectal cancer, you're at increased risk of getting cancer. If you have other diseases like inflammatory bowel disease, Crohn's disease, ulcerative colitis, puts you at high risk. Diabetes puts you at high risk. Alcohol use, obesity. This is a big one that people don't realize because we are a red meat loving state. Red meat consumption actually has been shown to have increased risk of colorectal cancer. Processed meat has been classified as a carcinogen. Smoking, of course. And what are the factors that can help decrease the risk? Well, physical activity is the big one. Physical activity and diet high in fruits and vegetables. Both men and women get colorectal cancer. True or false? Okay, somewhere there. Yes, there. She's been wanting this. There we go. That's correct. Even though the risk is pretty much me, a topic for me. We are caretakers, we are nurturers, we are in charge of our households, and we're taking care of our kids, husband, family members, but we often forget about ourselves. Okay, Oklahoma colon cancer screening rates, we are in the bottom 5 states in United States in terms of screening. Let's get those rates higher. Okay, um, African Americans are diagnosed with this disease earlier. They have barriers to care, so their treatments are delayed. So we all have to recognize that and do better. Audrey Hepburn is another very, very popular actress who was diagnosed with colon cancer and unfortunately died with it in 1993. And I think this is the last one. You can stop this cancer before it starts. Yes, her. Okay. Just, I think, thank you. So how do we prevent it? Well, screening tests. Screening. Screening is basically testing to find a disease in people who have absolutely no symptoms. And what are the screening tests? Well, colonoscopy, colon stool testing, like Cologuard fit testing. And I want to talk about colonoscopy a little bit and what colon polyps are. Polyp is a growth of tissue, just like a mole outside on the skin that can grow into cancer. It's a tissue like this, the growth, that has the potential of turning into cancer. There are two types of polyps, hyperplastic, very, very benign, very small chance for advancing into cancer, adenomatous polyps, which are the ones that can turn into cancer. So by removing these, we effectively prevent colorectal cancer. So let's talk about colonoscopy, the dreaded colonoscopy. Out of curiosity, how many of you have undergone that procedure here? Hey, these are my people. This is amazing. So, so what we do is when you're nice and sedated, we don't want to torture you. We take this thin scope, and it is a thin scope, and we go all the way to the end of the colon. And what I'm looking for are polyps, any other lesions, diverticulosis, inflammatory bowel disease, and most of the polyps can be removed endoscopically. And you go home within, an hour or two of this procedure. Screening saves lives. Age 45. 45 is the new 50. I want to point out this is the big question I get asked. What is the difference between stool testing and screening and colonoscopy? Well, there's one-step test. This is the best way I can explain it. One-step test versus two-step test. So the best screening is the one you get. So, if somebody is like, I'm not going to go for colonoscopy, sure. Go get your Cologuard. Go get your fit testing because I want you straight. But once you get the stool testing done and it comes back positive, then you have to undergo colonoscopy. So it's a two-step to be able to, get kind of the peace of mind that you are polyp-free, colon cancer-free,
One step with colonoscopy, we're looking for polyps, we're looking for other lesions, we're looking for other types of cancer that are non-adenomatous, like neuroendocrine tumors. So lots of different benefits for colonoscopy, but that's the best way I can explain. One step versus two step. But remember, if you have a stubborn family member who's like, don't you dare talk to me about colonoscopy, get them to do a stool test, okay? But remember, the stool testing is only for average risk people, okay? Not somebody who has family history of colon cancer, not somebody who has family history or personal history of IBD. So like I said, 45 is the new 50. So how do we prevent cancer? Just to review, get screened, 150 minutes of physical activity per week, plenty of fruits and vegetables. We have some great charcuterie board there. Get yourself some. And limit alcohol and red meat consumption. Keep calm and schedule your colonoscopy already. And this is, I know I'm probably over the time, but basically get screened. So thank you.
I gotta find my talk though. How do I do that? Oh, here, I'll just switch.
The more you rattle it,
You were not in.
I did. The more you wrestle around, look at that.
Like Adele. There's for Celine. There's an art. Yeah, I could definitely use a little thing of water. Thank you. How dare you say we don't prevent cancer?
That's what
It's true, though. There's no way to prevent it. Not yet. But we're getting really good at the death rates and treatment. And it's like 95% survivable, pretty much, if you catch it early, in the early stages.
Well, then cutting it.
Depending upon what type.
Down goes forward, up goes back. Whatever you see out here.
Well, that was fun. I hope it was. They're gonna kill me because I'm pretty sure I went to
Mine
work.
is going to be shorter, probably.
Okay.
So.
It was
This
fun
isn't
not
perfect.
to talk about it.
All right, guys. It's time to talk about breast screening.
Can we please get your attention to this lovely lady here?
Hi, I'm Dr. Anna Stidham. I'll be talking to you today about breast cancer and what you can do to prevent it. And yes, we haven't gotten to the point where we can absolutely prevent it like colon cancer. We can't take things out that might turn into it because the imaging just isn't quite there yet. And it's so heterogeneous. It can look like a normal tissue. So a little bit trickier there with that one. But our mission here at Premier Breast Health Institute is to detect early, streamline the process for care and treatment. And we feel like we have a good blend of advanced technology and compassionate care here. And so these are the objectives I want you to kind of keep in mind as I'm talking. And so I'm going to talk about how common breast cancer is in our community. The 4 breast self-awareness messages that I want you to take home and kind of one action plan for each one. One resource for breast cancer information, some common risk factors, and also I want you to share something that you learned at this talk with somebody that you care about. So how common is breast cancer? So in women, it's the most common invasive cancer. It's the second main cause of death after lung cancer in women. Different than combining male and women. So if we're just looking at women there, it's quite common, 1 in 8. And women in their 40s, it's 1 in 6. So it's pretty common. But the good news is that early detection does save lives. Breast cancer death rate have declined at least 42% during this time frame that has been measured. And most of the time, if we catch it in the early stages, treatment is effective and it offers the best chance of survival, 95 to 99% chance of basically almost a cure. But we can't cure aging yet, so that's there. So some of the breast self-awareness messages that I want you to take home with you: know your risk, get screened just like colon cancer screening, know what is normal for you, and then make healthy lifestyle choices. That's going to be the theme throughout here. So those healthy lifestyle choices are really big. So about your risk. So 90 to 95% of cancer is not associated with family history. So just know that you're not in the clear just because, oh, no one in my family's had breast cancer. It can just arise de novo. But so anyway, talk to both sides of your family, because there are some forms of cancer that are associated with breast cancer, like some forms of prostate cancer, some forms of colon cancer, some forms of pancreatic cancer. They're a related gene that can also be a breast cancer gene. So talk to your family members, get a good history from both sides, and then talk to your kids, because, you know, that's super important. Talk to your doctor about what personal risks you might have and what you can do to prevent and to decrease your risk. So here's some risk factors and risk reductions. So first thing to know is that risk factors don't cause breast cancer, they're just associated. Okay, so it's just like any other risk for anything else. They're just associated with an increased chance. Some can be controlled and some cannot. And here are the 2 most common risk factors: being born female and aging. Can't control those. We're stuck. But there's some other risk factors here that you can control. Over to the right side of the chart here. Here again, these are the 2 most common: being born female, getting older. Inherited genetic mutations, and then some types of tissue that you might have biopsy that comes back with certain types of names like atypia and lobular carcinoma in situ, which is not a breast cancer, but it's a marker for increased risk. Family history, of course, tied to inherited genetic mutation. Dense breasts. So dense breasts are not how they feel, but how we see them on a mammogram. So when we image the breast with a mammogram, you have whites, grays, and blacks, different shades. When your breast tissue is dense, there's a lot of white. Well, guess what cancer looks like? White. So when you have a lot of white, it's like trying to find a snowflake in a snowstorm. It can be quite tricky. Even with the advancements in 3D and the resolution of our monitors, it's still, when you have dense breasts, there's still a 30 to 40% chance that we will not see an early cancer with just mammogram. Mammogram is important though, because it does detect some cancers that other modalities cannot detect. And I can talk to y'all more about that individually if you have questions. So high blood estrogen levels, you know, we can't really control that, but one thing we can control is postmenopausal weight gain. So from the age of 18, if you gain, this is going to be really depressing, but if you gain 20 pounds from the age of 18, your risk actually goes up, because our fat cells actually convert inactive estrogen to active estrogen. So obesity you have more estrogen with obesity. So estrogen levels are a risk factor. Obviously, previous personal breast cancer, no children or first child after age 35, and not breastfeeding are because the breast tissue goes through different differentiation. The cells learn what to do when you have a child, and they learn what to do when you're nursing. But when you don't do that, they're kind of like, hey, I'm going to do whatever I want. I'm going to secrete this. I'm going to make fluid. You know, they don't really know what they're supposed to do. So your chances of cancer can increase slightly without those 2. So those are protective. Drinking alcohol, just like colon cancer, smoking, and then no physical activity. So get moving. So get screened. Talk with your doctor about what screening tests are right for you, and if you are at higher risk. If you're not at higher risk, then the age is 40 here. 40 to start your annual screening mammograms every year, because studies have shown that if you skip a year, there's like 55% chance that we're going to miss a cancer that might have happened in that time interval that we could have caught earlier. Clinical breast exams are back in fashion every 1 to 3 years starting at age 20 and every year starting at age 40. So go see your gynecologist, even if you're not having a pap smear. And then you can sign up for screening reminders also at komen.org, and they'll actually email you when it's time. So that is another way of keeping track. Or you can do it annually on your birthday, or same day or same holiday. Pick a holiday. So mammograms in the U.S. are the best screening tool available because it has been the one modality that has shown decreased death rates. It can be used as a diagnostic tool. Clinical breast exams are important. Know what's normal for you. So here are some signs. They're not all associated with cancer all the time, but here are some signs that you need to be looking out for. Of course, a lump or a hard knot or a thickening in your breast, swelling or warmth or darkening of the breast. Breast cancer can look like an infection, so always get that checked out. If you're going to antibiotics and it doesn't resolve, definitely go get it checked out. Change in the size or the shape of your breast. This is a sudden change. All women are asymmetric, but a sudden change without association with weight gain or weight loss is something to be concerned about. Dimpling or puckering in of your skin. Sometimes the cancer can start pulling on tissue, and that's the way it can appear. Itchy, scaly, or sore rash on your nipple. Some forms of breast cancer just happen in the nipple. Pulling in of your nipple or other parts of the breast. Again, just like that skin dimpling action, if it's new and if it doesn't resolve with stimulation. Nipple discharge that starts suddenly, or a new pain in a new spot that doesn't go away. Here are the healthy lifestyle choices you've already heard about. Limit alcohol intake. 1 drink a day isn't going to get you there. It's dose dependent, so it's the excessive alcohol. Exercise, maintain a healthy weight. Breastfeed if you can. Limit postmenopausal hormone use. And here's your review screen. I've been told that I'm past my time, so we'll answer questions at the panel. Thank you. Oh. At the end, like a test. Like name one or something.
Skin cancer, REV.
Okay, I'm gonna email this to myself. In the back.
And you actually brought some of it. So that I wanted to ask you about the colorectal or something. So my husband said he did something that he mailed, or it could be different.
Okay, you're all set.
Thank you.
So just down to go forward, up to go back.
Okay, perfect. Thank you. It does work, but it won't project on the screen.
Yeah.
Because it's not a. Okay. Yeah. Good morning, everybody. My name is Pranithy. I'm a dermatologist. I work in Edmond. It's a pleasure to be here to talk about skin cancer. It turns out May is Skin Cancer Awareness Month, so this timing is perfect. I'm going to get started with a question for the audience. I didn't have the foresight to bring t-shirts, so we'll be, oh yeah, there's a gift bag. Thank you. So can anyone tell me what Bob Marley, Hugh Jackman, Khloe Kardashian, and Nora O'Donnell all have in common? Skin Skin cancer, yes. Can someone tell me which skin cancer they've all had in common? Very good, yes. I don't know, a lot of people had it right. So they've all had melanoma, and I'm going to start the talk with a conversation about melanoma. There are 3 most common skin cancers. This is the most dangerous of the 3. So we're going to focus on this first. What is melanoma? I think there's a lot of confusion about that. We have a lot of patients come for their skin checks and they say, my mom has had a melanoma or my grandpa had a melanoma. And then when we ask more questions, they'll say it was burned off their skin. And that's an immediate, kind of clue that it was probably not melanoma. So we're going to look at this picture for just a few seconds. And this is a cross section of the skin. This topmost layer is like frosting on a cake. This is the epidermis. And this is where the 3 most common skin cancers arise. So we're looking at this little sliver at the top, and this is a close-up view of that sliver. So if you look along this lower layer, there's a special cell called a melanocyte. It's in blue. A melanocyte is a cell that produces pigment called melanin, and melanoma is a cancer of the melanocyte. So it's a special cell that produces pigment, and when it proliferates abnormally, you have a melanoma. There will be an estimated almost 250,000 cases of melanoma this year in the United States alone, and that's not accounting for worldwide. There's a very high incidence of melanoma in Australia, New Zealand, other countries. So what are the risk factors? Skin type is a big risk factor. Having fair complexion, especially fair complexion with red hair, a tendency to freckle, a tendency to sunburn easily. That is the skin type that we are most concerned about. Having said that, any skin type can develop skin cancer. So I don't want anyone to leave here with the misunderstanding that if you're not a redhead with fair skin, that you cannot develop skin cancer. But that's a uniquely susceptible population. Sunburns are very damaging to the DNA of all of our skin cells. Having more than 5 sunburns, they don't have to be blistering, but blistering ones are especially problematic. They are especially problematic if they happen before you were 20 years old. So preventing a blistering sunburn in a child at 8 years old significantly reduces their risk for melanoma in the future. So we always screen for that. 5 or more sunburns at any point in your life doubles your risk for a melanoma. I have Hugh Jackman here because he's Australian, and in Australia, the intensity of their ultraviolet radiation is very high. So it's a very high incidence of melanoma in that part of the world. Tanning beds are a huge risk factor. Tanning beds are banned in Australia, Japan, and Iran. I didn't think that was a country that would have tanning beds, but they're banned. Tanning beds are classified as a class 1 radiation risk, along with cigarettes and plutonium by the World Health Organization. Any tanning bed exposure in your life will increase your risk for all skin cancers, and melanoma in particular. And the more times you've used a tanning bed, obviously it's a dose-dependent risk. So it is something that must be, it's a practice that has to be terminated. And Khloe Kardashian has used tanning beds. Immunosuppression. Immunosuppression can be from having received chemotherapy for cancer, having an autoimmune illness like lupus, where you took medications to suppress your immunity. Also, organ transplant and stem cell transplant patients are uniquely susceptible to skin cancer from their anti-rejection medications. So they have to have regular screenings. Patients with chronic lymphocytic leukemia, which is an indolent hematologic malignancy, are immunosuppressed as well. So that's a risk factor for all skin cancers, including melanoma. Also, what does your skin look like? Do you have a lot of moles? Do you have more than 25 moles? What do your moles look like? Are they large moles? Are they all sorts of shapes and colors and sizes? Are they very diverse? That is an additional risk factor. There's a misconception that removing every mole or taking off all the moles you don't like on your skin would somehow decrease your risk. That is not the case. 70% of melanoma arises on normal skin. It is not a pre-existing mole. 30% of melanomas do arise from a pre-existing mole. So you have to watch your moles, be familiar with where they are, what they look like, watch for changes, but most importantly, watch for something new or unusual that pops up. Skin cancer history. So patients who've had multiple basal cells, squamous cells, their risk for a melanoma is higher. And lastly, family history plays a larger role in your risk for melanoma than it does for the other skin cancers. So there are certain genetic syndromes that have a higher associated risk. If you have a BRCA2 positive mutation, your risk for melanoma is higher. CDKN2A is another mutation that increases your risk for breast, colon, and melanoma. And if you have a first-degree relative who's had a melanoma, your risk is much higher. So know your family history precisely. Is it because there's so many people that come in with that family history, and we just sometimes don't know if it's a real melanoma. So you just want to know, make sure that that risk is well understood. First-degree relatives, parents, sibling, or child can increase your risk. So this is what everyone knows, the A, B, C, D, E's of melanoma. Very quickly, asymmetric, both sides don't match each other, an irregular border, multiple colors, large diameter, and E is for evolving, which is something changing. But I want you to take away a different sign today, which is the ugly duckling sign. How many of you have heard of an ugly duckling sign? Has anybody heard of it? Except for Carrie, my MA, who's here. Who hears this 20 times a day. So ugly duckling sign is the takeaway. So what is an ugly duckling? It's the spot on you that's different than the others. It doesn't have to be the larger one. It doesn't have to be the darkest one. It has to be the odd ball. And we'll look at some examples in a second, but that's a sign of either a melanoma or a severely atypical mole. So now we're going to go into the clinic and look at some cases of melanoma that we've biopsied. And this is, I showed this image to show, this is the instrument we use to screen for skin cancer. It's called a dermatoscope, and it's just a magnified lens with the bright LED light. A lot of patients think it'll light up a skin cancer, and that's how I know it's like a metal detector. If only it were that easy. It's not. Okay. So this is an example of a melanoma on the leg. The legs are the most common place, the buttocks and legs are the most common place for melanomas in women. Because unlike the other skin cancers, melanomas show up on parts of our body that have been exposed to intermittent high doses of ultraviolet radiation. So legs are usually covered up, but they get exposed in the summertime, skirts, shorts, bathing suits. For men, it's their back or their torso in general. The shirt comes off, they're mowing their lawn, they're on the beach. So these places that are not always exposed are more commonly affected. So you can see this spot on the leg. Under the dermoscopy, it's an irregular brown macule. Here's a spot on the back of the ear. Just looks like a darker freckle, but we use our dermoscopy clues to kind of distinguish it, and we did a biopsy, and this was also melanoma. This is a spot on the bottom of the foot. For the longest time, she thought it was a pebble that created some type of bruise or injury. It kept changing, and this turned out to be an invasive melanoma on the bottom of the foot. So this is a great picture of a melanoma hiding amongst the barnacles that grow on older folks. So these dark, crusty, harmless skin tag type lesions, and there's some melanoma within that cluster. This is a great example of an ugly duckling. A very small spot on the leg, and this was early melanoma. There was nothing else like this on any part of her body. This is a classic melanoma on the back. This was a woman who was a construction worker, actually. Another type of melanoma is called lentigo maligna melanoma. These are more common on sun-exposed surfaces like the head and neck, and they're indolent and slow growing. And this looks like a small freckle that starts to grow in size. This is on the back of the arm, and this is on the upper arm, just a classic melanoma. Here's an example of an invasive melanoma. He was a landscaper. He came in with this nodule that was growing rapidly. It was removed. There's a skin graft, and a few months later, there was a recurrence nearby. Acrolentiginous is melanoma on the palms and soles, or the nail unit. It disproportionately affects persons of color, and Bob Marley died from this at 36. He thought it was a soccer injury. What determines the prognosis? How deep it goes. So the earlier you catch melanoma, the better the prognosis. The deeper it goes, the more likely for it to go to lymph nodes. So treatment, you cut it out. You might need a sentinel lymph node biopsy, lots of new therapies for advanced melanomas. PET scans can show distant metastases. 99% survive in 5 years if it's detected early. So we're going to move on to the most common skin cancer, which is basal cell. 3.6 million people are diagnosed with that yearly. Again, looking at this picture, you can see basal cells are also in the epidermis. They're at that bottom layer of skin. I'm sorry, I'm trying to go as fast as I can. Oh, okay. So basal cells look like a crusty spot, a pimple that won't go away, a sore that won't go away, and these are on sun-exposed surfaces. This was a morpheaform basal cell, looks like a scar, and this is on the back of the ear, a very common presentation, an ulcerated nodule. The nose, the bottom third of the nose is the most common place for this. It can be pigmented. This was a dark basal cell. It can look like a scaly patch of eczema on the back or the arm, classic presentation on the forehead, and we look at close-up. This little tortuous blood vessel is our telltale sign. It's the basal cell. But basal cells, very common. They're curable. No one really dies from a basal cell unless it's very it's advanced. But they can be locally destructive, so they have to be taken seriously. Squamous cell I'm going to talk about in the same context. It's the second most common skin cancer. 1.8 million people are diagnosed. Squamous cells are different from basal cells or melanocytes, and they often present as precancerous patches called actinic keratoses. Those are crusty red spots on sun-exposed skin. 58 million people have these, and they're treated with liquid nitrogen, and they're prevented with sunscreen. So squamous cells look crustier. They look like warts sometimes. Always sun-exposed surfaces are preferentially affected. Here's some advanced squamous cell carcinomas that look like very large crusty nodules. Risk factors are slightly different. 50 plus, men more commonly get squamous cell carcinomas, but that's changing. Women are getting more. Sunburns, tanning bed exposure, immunosuppression, skin cancer history, and skin type. In an organ transplant recipient, 100 times more common to get squamous cell carcinoma. So how are these non-melanoma skin cancers treated? I'm sure some of you have heard of Mohs surgery. This is done under a local anesthetic. It's staged excision. So the surgeon removes a sliver of skin, checks under the microscope to make sure all the skin cancer cells are removed. And this is done for non-melanoma skin cancers in specialized places, like the scalp, face, ears, hands, functionally and cosmetically sensitive areas where you don't want to take a big chunk of skin out. So that is the standard of care. If it's on the back or arms, you can have an excision. They can even be scraped or treated with the cream if they're superficial. 99% cure with Mohs. Merkel cell, Jimmy Buffett brought this to everyone's attention. It's rare, but it's aggressive. It's 3,000 cases per year. It's usually an asymptomatic nodule that's growing rapidly. It's men usually that are affected, older than 50, lots of sun exposure or any immunosuppression. This was a case we had in clinic of a Merkel cell that grew explosively over a 6-month period because it was not treated. They deferred treatment because of her dementia. Okay, prevention. So sunscreen is key. Everyone asks in clinic, what is the best sunscreen? It's the one that you're willing to wear every day. The SPF has to be at least a 30. Reapply if you're sweating or swimming. And don't underestimate shade. Staying out of the sun between 10 and 4 when the UV is at its most intense. Protecting children from getting sunburned. And reapplying sunscreen throughout the day is very important. And then if you're near water, on the beach, snow, skiing, your UV is amplified in those environments. You have to be more careful. What about vitamin D? Do not get it from the sun. Get it from your diet, get it from your supplement, and avoid tanning beds at all costs. How to spot? Check yourself monthly. Become aware of your moles and have your hairdresser check your scalp. Check yourself thoroughly and be vigilant for anything new or changing. When should you get a skin check? How young? It depends on your individual risk. Unlike breast and colon and cervical cancer, there are no guidelines about when to start that screening process. So the risk factors we talked about, if any of those apply to you, have a baseline skin check done with a board-certified dermatologist to establish that risk. This is Spectrum Dermatology in Edmond. We'll have a location in Nichols Hills in a few months. We have an all-female cast and crew, and everyone's wonderful. My nurse Carrie is here. We've seen thousands of patients together and done a lot of these biopsies together. So it's a wonderful place to work. You're welcome to come see us, and happy Mother's Day to everybody. Thank you.
I was really happy that they asked me to talk about cervical cancer screening because it's not as glamorous and it's very common. A lot like colon cancer screening, we do have a really great screening tool that can prevent cervical cancer from happening, and that's what the pap smear is. So this annual exam that everybody dreads doing is not just an exercise in female embarrassment. It is to keep you safe and healthy. They do recommend that you have an annual exam once a year. We don't always do a pap smear every year. I guess I should back up actually and tell you that your cervix is the bottom part of your uterus. It's like the opening of the uterus. And those cells within the cervix are prone to grow quickly and turn over quickly. And so that's why they're a little bit more likely to develop cancer than other cells. Cervical cancer is unique in that almost all cases come from infection with a virus called the human papillomavirus, HPV. That is a sexually transmitted virus, and it's very, very common. Most people who have had sex have probably been exposed to it. It infects those cells of the cervix and causes them to grow abnormally in ways that can go on to lead to cancer. The good news is that most people have healthy immune systems and can suppress the virus and heal those cells and return them to normal. But we don't know who is going to suppress the virus and heal their cells and who will go on to develop cervical cancer. So during your annual exam, we do what's called a pelvic exam, where we use a tool to look inside your vagina and see the cervix. There are some cancers that are fast growing, and that's how we detect them, is that visual survey. But most cancers are pretty slow growing. It takes most people about 10 to 20 years to go from the pre-cancer cells to actually developing cancer. And we detect that by doing the pap smear that everybody kind of knows about. We use a thin, flexible little brush to sort of sweep those cells away from the cervix, and we send them off to a pathologist who looks at them under a microscope. The pathologist is able to see some abnormal growth and changes in the cells and their behavior and their shape, and determine that, okay, this is a precancer, what we call dysplasia. They're also able to do testing for the human papillomavirus. They look for some of the most common and aggressive strains, and that tells us what your risk of developing cervical cancer is. If we find that you have an abnormality or that you tested positive for HPV, there's some further testing we can do, and sometimes we even remove those abnormal cells and keep people from getting cervical cancer. We used to do cervical cancer screening every year. You turn 18, you get your first pap smear, and you're supposed to go every year until you die or you will die. And that was like a really powerful message, and it's really hard to move away from that. Not too long ago, I think about 10 years ago, there was a group that sort of looked at cervical cancer and how it behaves and how it progresses, and tried to make some changes to how often we do these tests, because while we detect early stages, most of those don't go on to lead to cancer. So finding these abnormalities resulted in some people getting procedures that they never needed, and they're painful and it's stressful. So they kind of came up with an ideal interval for how often we should do the cervical cancer screening. It starts at age 21. We don't do them earlier anymore because A lot of people in their younger years have HPV and will be able to suppress it and maybe never even know about it. You suppress it to undetectable levels and it doesn't cause a problem for you. So we wait until age 21 to do that first pap smear. And in your 20s, you get a pap smear every 3 years as long as your paps are normal. When I say pap smear, I mean that we take the cells, the pathologists look at them under the microscope. In your 30s, we start to do testing for HPV as well as looking at the cells. And that kind of helps us gauge your risk. If your cervical cells are normal and your HPV testing is negative, you actually get a pap smear every 5 years. Now, they do still recommend coming to see your PCP or your gynecologist once a year. We do breast exams and we screen for other types of cancers, but you only get the pap every 5 years in your 30s, along with HPV testing. Sorry, I lost my train of thought. So we don't do them every year. Oh, and then we continue those until age 65. And if you've always had normal pap smears, you've been regular about showing up for your exams, the chances that you will get cervical cancer after that point are low enough that you don't have to do the pap smear anymore. They do still recommend seeing a doctor once a year and having a pelvic exam because there are other things that we screen for as well. But that's always a relief to some people, except for those of us who got that message that you have to do it every year or you'll die. It's a little stressful. So there are some risk factors for cervical cancer. The main risk factor is exposure to HPV, which most people are exposed at some point in their life. But there is a vaccine that was developed about, I'm trying to think, I was in medical school, like 14 years ago, that can prevent the 9 most common and aggressive strains of HPV. And I think with time, and as we get more people on board for the vaccination, we'll see less and less of these abnormal pap smears and cervical cancer throughout the world, and certainly the United States. It is approved for people from age 9 until 45. Kind of the ideal time to have the vaccine administered is right before the initiation of sexual activity. So they recommend it now between 11 and 13 years old. If you have kids who see their pediatrician, they may recommend that around that age. Also, if you are a smoker, that suppresses your immune system and makes it more likely that you may not be able to clear the HPV. So we recommend stopping smoking. And then things you can't really control are immunocompromised, which is so many cancers. I think everybody mentioned that. People with AIDS, and so people who have those increased risks are supposed to do PAPs every year. So HIV positive, if you are on an immunosuppressant medication, and not if you're a smoker, but you should just stop smoking. So that's all.
Okay, well, I want to say thank you to all 4 of you lovely doctors. So I think screening is so important and it's something that we need to focus on and don't necessarily pay enough attention to. So a couple of different things. Screening is, you don't have to have a referral from your doctor to be screened. So if you need a screening mammogram, you can call a breast center, call here, we can schedule it. If you need a colonoscopy, you can schedule that with your GI doctor. So all of their cards and information are up here. Most of you have cards and information in your bags. We're gonna do a short panel session, like 3 questions with you guys, and then they're all going to be around. So you're welcome to just stop and visit, ask questions. I think we've got some sunscreen over here, little samples of sunscreen in a bowl. So if you need some sunscreen or you want to try something, then stop and pick some up. So we'll do like 3 questions. Anybody in particular have a question? There's a gift bag for questions. See? That was loud. Any questions for these ladies? Okay, I'm going to walk back here. It is a long walk. I didn't process that.
So I have a family history of pancreatic cancer, and I see a lot of screenings for so many types of cancer, but not pancreatic cancer. My mother and my grandmother, her mother, died of pancreatic cancer. And so when I asked my family doctor, about this and what can I do, she basically said, there's just no screening for it, sorry. And so I'm concerned and curious as to what you guys have to say about that. Oh, thanks, Stephanie.
for bringing that up. That's something we struggle with. So screening tests, as we mentioned, are tests that are for early detection, and it has to show benefit. Pancreatic cancer is very rare, and to the best of my knowledge, we don't have a screening test yet. However, advocating for yourself, sharing your family history is extremely important, and I would recommend, meeting with a genetic counselor because pancreatic, yes, the genetic counselor can help map out your family history. There are some blood tests like SPINK1, PRSS1 as well that test specifically genetically for pancreatic cancer. I have some patients who come to me and ask the same question. So I set them up with a genetic counselor to get that genetic testing. And then, even though the imaging is not necessarily approved, we have a discussion regarding, let's get, a CT with pancreatic protocol at baseline, just to have some baseline to start with. Again, these are not guidelines because there is no screening protocol, but a genetic testing is, from my perspective, very important because other syndromes like Lynch syndrome, which is HNPCC, can affect other organs too. So my advice would be meeting with a genetic counselor, and I believe we have one.
So we definitely have a genetic counselor here, and there's some little cards around, and if there's a QR code on the card, if you scan it and you answer the questions, it will tell you whether you qualify for genetic testing, whether that's breast, ovarian, pancreatic, and it will send a link to our genetic counselor, and she'll know that she needs to call you to set up an appointment. So those cards, there may be some in your bags, but we've got them all around. So that's something that was real important to us in all this.
You're welcome. I am so glad you asked that question because that's not people don't know about that. So
You have a question, Donna?
So I had a partial hysterectomy at 40. It was emergent, but I did not have an oophorectomy. So now I'm 65. Do I need to worry about my ovaries, or are those like raisins now?
They do tend to raisin with time. That is part of why they still recommend doing that annual exam. And after the age of 65, it's a little tricky because sometimes Medicare won't pay for a yearly exam. My personal approach to that is to try to find a problem to talk about so we can kind of bill for the problem one year and the annual the other year. It would still be recommended that you have a yearly exam to evaluate your ovaries and to talk to you about symptoms that could be ovarian cancer. We also still do the pelvic exam because with age, it's more common to have cancers of the vaginal tissue and the vulva. So I didn't exactly answer your question. I will say ovarian cancer is very rare. It's not a common cancer. So there's no screening for it, pretty much. And actually, it's a pretty poor test for actually detecting early ovarian cancer. We're not very good at it yet. That's all we have.
Okay, one more question.
Yeah, that's true.
Oh, I'm gonna end it right here. I just saw your hand first.
Hi. What is the limitation of Cologuard?
Yes, so Cologuard, the stool test. There are two big Cologuard. Cologuard is DNA test, stool DNA test, and now there is ColoSense, which is a multi-target RNA test. These two tests, the whole job is you package your stool, you send it off, and what they're detecting is either DNA or RNA, and that's shedded from the cancer that could have developed. So that's what they're testing, and they're testing adenoma cells in the stool. So going back to the first step, 1 step and 2 step that I talked about, that's really, really important because the benefits of stool testing is accessibility. People can do it at home. They don't have to worry about the prep and coming in and getting a colonoscopy. The downsides, there are two main ones in my opinion and in the GI community. One is the sensitivity and specificity. So they're very sensitive in testing for colorectal cancer. They're not as sensitive in picking up advanced adenomas or early adenomas in the polyp. And that's a very important point. So the sensitivity is good, for cancer, it's moderate for adenomas, but specificity is low. What does that mean? That if it is positive, does that mean you definitely have cancer or polyp? No, you tend to have a lot of false positives. So the number of times I'm getting texts from my colleagues, please get my patient in because they had a positive Cologuard and they're very anxious, is very, very high. Because once you get a positive Cologuard, you Google and you just cannot sleep, understandably so. So that's the big.
Thank you, ladies, very much. So we're going to wrap up and take a break. So we're going to shorten our break from 15 minutes to like 7 or 8 minutes. But there's bathrooms back in the back. There's a couple of bathrooms in the clinic itself. There's some bathrooms upstairs, and there's lots of food and drinks over here. So help yourself, and we'll see you again in just a few minutes.
Because he's arguing with me that he doesn't need a colonoscopy now. When we get to
I did forget to mention that you have evaluation forms for this session in your chairs. If you fill out those evaluation forms and turn them in the back, we're going to do a name drawing at the beginning of the next conference for one of our big door prizes. So fill out your forms and take them back to the back, and we'll put you in the name drawing. Hey, how are you? You look great. Good. Okay, it's time to make your way back to your seats here. If you didn't fill out your evaluation form, now is the time. We're going to draw names right now, and we're going to do a gift basket giveaway, but you had to fill out the evaluation forms. So anybody else have session 1 eval forms not ready? Okay. Yes. Is that, yes. If that's session, was that session 1? Okay, perfect. All right, so session 1 eval forms, and then we're going to draw a name. You just want to fold them up. Are these session 1? These are all session 1s, right?
We have them. Denise is writing their name down.
Oh, perfect. Okay, she's drawing it.
Oh, more?
No. Yep, you got it. Yep. Hold on.
There's 2 right here.
Right here. Okay, I'm gonna let her finish. I'm gonna introduce people. So our second panel session, the first talk is going to be about skincare, aging prevention, and maintenance. Did I do it wrong?
It's aging gracefully.
Aging gracefully is right. Skincare, aging gracefully, and maintenance. And Dr. Bajaj is going to talk to us about that. Dr. Parker is going to talk to us again about hormone replacement therapy this time, other options and treatments. So we're excited to hear about that. And then Natasha is going to talk to us about love and intimacy and the different seasons of our lives. And so I think everybody who's turned one evaluation for the last one is up here. So Dr. Bajaj, you want to draw a name for us?
Jenny Hester. Jenny Hester, first winner.
Oh, there she is.
There. What are we giving her?
Whichever one you want. Yep, the other one's a spa, med spa.
Okay, I'll give you my
Okay, Dr. Bajaj is going to get started.
So, did she or didn't she? Secrets to aging gracefully. And so, one question that everybody has is, what does it mean to age gracefully? Is it anti-plastic surgery? Is it having too much plastic surgery? And I actually had a patient yesterday who said that to me. She's like, I always thought I was going to age gracefully, and plastic surgery seems really extreme. And that's probably because when we think of plastic surgery, we think of bad plastic surgery. And the reality is, good plastic surgery is the plastic surgery you don't see. And that's aging gracefully. In general, as we've learned, things like sun exposure, an unhealthy diet, and whether or not we take care of ourselves has its effect on us, including genetics. And we do age, and our faces do change how they look with time. And there are things we can do to age gracefully. And that's sort of what I want to talk about today, in addition to defining what is. I think of aging gracefully as more of an attitude. It's how you carry yourself. It's about being confident in who you are and living your life the way you want to. And I think these are some examples. Helen Mirren has aged beautifully. Jane Fonda has aged beautifully, and she's actually embraced plastic surgery, and her outer self reflects her inner self, and that's important. That being said, one of the things I talk to all my patients about is the importance of daily maintenance. Think about it this way. If you went to the dentist once every 6 months and didn't brush or floss in between, your dental visits would be a disaster. And the same thing is true for all of your aesthetic treatments. One single aesthetic treatment, whether it's 30 minutes, 4 hours, 2 hours, is not going to reverse what you have done for the past 20, 30, 40, 50, 60, 70 years.
And so that's why I refer to it as the 80-20 rule. In reality, 80% of what you can do to look good comes from you. And the other 20% comes from what I do or other types of aesthetic treatments. One really well-known plastic surgeon actually put it this way, and he practiced in Dallas and was really well known for facelifts in the 70s and 80s. And he said, no matter how fine the tailoring, you still have to deal with the fabric. And that's kind of true. This is a pyramid kind of making the same point. And as you can see, that the top layer is the more advanced things if we're going to talk about skin treatments. So this is something I posted on Instagram comparing how I feel like I've aged over the past few years. And most of you may not know, but I'm 55. And, you know, I think it's important as we think about aging, what we can do to improve it. And when people ask me what my secret is, I usually say, well, I'm a plastic surgeon. I have everything at my disposal, which is kind of true. So to that end, we have a group of female plastic surgeons, and we always talk about what we can do to age gracefully. And we did a survey on our Facebook group page and wanted to ask female plastic surgeons, what are the top 10 things you can do to age gracefully? And most of it is stuff that you already know. Number one is sunblock. You have to remember that sunblock is important to protect your skin, and it's going to protect against UVA and UVB rays. And you really need to use it every day. And as we discussed, it should be a minimum of SPF 30. I think it's important when you use sunblock, it should be titanium dioxide or zinc oxide, which is an actual barrier. So don't do the drugstore sunblocks or sunscreens. Do real medical grade sunblock. The next thing would be intentional eating and weight maintenance. I think it's really important that all of us find a nutritional plan that works for us. I'm not gonna say diet because diet is temporary. The nutritional plan is how we can live our lives every day and eat the things we want to. And I do believe that there are certain foods that some people can tolerate and other people can't. And you have to find what works for you. And it's important to maintain your weight. As we've discussed already today, gaining weight puts you at risk for cancer to some degree. And also gaining weight wreaks havoc with your skin and elasticity and your tissues and all of that stuff. So weight maintenance. And then of course, toxins and fillers used judiciously. There are many brand names out there, but I think it's important that you use them judiciously. One thing that most people don't realize is that Botox was first used for medical indications. It didn't get approved for cosmetic indications until 2002. And we used to use it for spasm and all strabismus and multiple medical uses. And now people only think of it as a cosmetic treatment. So the way Botox works is it decreases the wrinkles that are caused by animation. So as we grow, as we age, our skin loses collagen and elasticity, which means it has less ability to bounce back, which is also partly why weight fluctuations can be so detrimental. But it's also why, as we age, those wrinkles become more and more permanent, sort of like when you take your coat to the cleaners and that crease gets ironed in, and no matter how much you straighten it out, you can't. And what Botox does is it weakens the muscle, so hopefully those deep inset creases don't happen. And we usually use it in many places. Most of you are probably familiar with your frown lines, your forehead. We can use it on your neck for your platysmal bands, your frown, you know, right here, which I call my resting bitch lines, anything. The other thing that's really common is obviously fillers. That's another important treatment that all plastic surgeons partake of. Most people don't realize I've been doing toxins and fillers on my own face since I was 30. And so I still think I look fairly natural. So when they're done appropriately, they have the ability to look natural. Hyaluronic acid fillers are the most commonly ones used. There are multiple brands and there are multiple types. And the molecular structure and water absorption capacity determine where we inject them and how deep we inject them. The reason fillers are important is once we reach our 30s, the cruel joke of aging is everywhere else on our body, it becomes more and more difficult to lose weight. But we lose volume in both our superficial and deep fat compartments in our face. And then that compounded with the natural loss of collagen and elasticity in our skin ages our face and begins to give our faces a more square appearance. So fillers are usually performed, in the office. They're pretty straightforward, usually use topical and ice for local to numb you up, and it's pretty comfortable. I would be remiss if I didn't mention these are medical procedures, so choose where you go wisely. Obviously, the risks with Botox are more temporary since it only lasts about 3 to 6 months. Frequently, you can get ptosis or spread of the toxin. We've also heard recently in the news when people have had counterfeit Botox, which is not good. Fillers do have the ability to be more problematic. If you have intravascular injection, you can have tissue necrosis, blindness, and multiple other complications, including hypersensitivity reactions and infections. So number 4 was deep tissue massage because it feels good and it relaxes you. Number 5 is another thing we've also discussed, which is weight training and exercise. Remember that as you age, you lose muscle mass, and to maintain it, you have to stay active. And that's also going to be critical for nutrition and weight maintenance. Easy, drink enough water. None of us are good at it. I don't. I'm in a chronic state of dehydration. As we talked about the basics of good skincare, I'm going to put in a plug for medical grade skincare because I think that's important as well. That's how you maintain your skin. One of my patients asked, well, what's the difference? It's just more expensive. But there is a difference. It has higher quality ingredients. The ingredients are more concentrated, allowing for deeper penetration. And they have FDA oversight, which means when medical grade skincare makes claims, they actually have to follow through with those claims. Decrease alcohol intake. As we've discussed also, that decreases your risk of cancer. Hang out with people you laugh and do the things that you love. Find your passion and live your life because that's the way you're going to age gracefully. And the final one, I find that as I get older, I need more sleep, but we're going to talk about the sex component. But one of my friends who's a plastic surgeon was like, don't ever forget about the great sex. I was like, okay. And my take is have a great pair of shoes. So I guess what I just want to sum up is aging gracefully is about what you do every day to take care of yourself. And then the aesthetic treatments are the icing on the cake. Because I do believe when you look good, you feel good. And when you feel good, you look good.
Well, I'm going to do my best to be present with you because now I'm thinking about my work and my little children and how little I sleep and the impact it's having. They asked me to talk about hormone replacement, and I think it's really important to kind of clarify what hormones we're talking about. Because in general, just when we talk with each other, we say hormones and we mean something very specific and something very female. But the truth, and usually it's kind of not very nice, you're hormonal, so you're being crazy or you're being irrational. But the truth is hormones are just chemical signals that tell our bodies to do certain things. When we talk about hormone replacement therapy, specifically those female hormones are estrogen and progesterone. Those hormones are produced by our ovaries. And they kind of have a lifespan that's shorter than the human lifespan. So for most American women, the average age of menopause is about 51. And when an OBGYN says menopause, we mean that it's been a whole year since you've had a period. It's been a year since your ovaries have produced eggs and produced estrogen. Now, that said, our lived experience in our body of menopause is a little different. There's that perimenopausal period a few years before and after, and sometimes the rest of your life, where you may experience symptoms of lower levels of estrogen. Estrogen is a hormone that before menopause you make while you're growing an egg. And then as you go through menopause, your ovaries kind of stop making it, and it has effects on our brain, on our breast, on our skin, and on our uterus. Specifically, in terms of like our brain, there is a center in our brain that regulates our temperature regulation. So that's kind of the most common thing people complain about, is that they have these hot flashes that all of a sudden, and it's not just that you get hot more easily than other people, it's all of a sudden you're kind of hot from the inside out. And that comes from low estrogen levels. Estrogen replacement therapy is a good way of treating those symptoms. Unfortunately, estrogen tells the lining of your uterus to grow, so just taking it by yourself increases your risk of uterine cancer. So when people still have the uterus, if you haven't had a hysterectomy and you're having menopausal symptoms, we prescribe estrogen, and we also prescribe a second hormone called progesterone. Progesterone kind of mitigates the effect of estrogen on our uterus and prevents it from developing cancer. There was a big clinical trial looking at the safety of hormone replacement therapy back in the early 2000s. And the media really kind of covered it in an unfortunate way. And it made a lot of people really afraid to take hormones and afraid of hormones, that they were bad for their health. And the truth is, there are some risks. There is an increased risk of coronary heart disease. There's a slight increased risk of breast cancer and an increased risk of stroke that we learned from this study. However, when you looked at women who just initiated hormone replacement therapy around the time to the transition of menopause and didn't wait more than 10 years to start these medications, their risks were quite a bit lower. So I think with anything, you kind of have to balance the potential risks that might be small and then your quality of life. I see some women who go through menopause and they never have a single hot flash. They just stop having their periods one day, and they never really know about it. And then I see other people who have terrible hot flashes multiple times a day into their 70s. And so that's just not really sustainable for life. And so what we know, and what my professional organization recommends, is an estrogen. And there are pills, but they don't tend to be as absorbed as well. If your insurance will pay for you to have a patch or a transdermal, like a gel, that tends to work a little bit better. And then the progesterone is a pill. I typically recommend that people take that progesterone to prevent endometrial cancer at night, because it does make you very sleepy. I have a handful of patients who don't have hot flashes anymore. They don't want to take their estrogen anymore, but they will never let go of their progesterone because it helps them sleep so well. FDA approved estrogen and progesterone is kind of the main, most helpful treatment for menopause. Unfortunately, the data shows that it really helps with those hot flashes. Some of the other more distressing symptoms of menopause, like the brain fog or the skin changes, the hair changes, the joint pain, the clinical trials don't really show that it helps as much with those. Now, that said, anecdotally, I feel like a lot of my patients do feel much better, report better mood, feeling sharper. There are some non-FDA approved hormone replacement therapy options. I think they are really good at advertising that involve giving systemic testosterone and what they call bioidenticals, which are not bad, but they are kind of made to be like more natural and closer to like what's natural in our system. And the truth is, because they're not FDA regulated, we don't always know exactly what's in them. And when they test these, a lot of times they don't even have very good levels of the hormone that you're hoping to get. So that's not to say that sometimes people don't feel benefit. I do have patients who regularly get some of these kind of off the books treatment and feel really good, and I'll never convince them not to do it. But what we know is safe is that estrogen replacement therapy. I'm trying to think if there's anything else. So I think that we talked about some risk factors, but if you initiate your hormone replacement therapy around the time of that transition to menopause, those risks are fairly low.
Well, Well, first, I wanted to say that I feel so empowered today listening to everyone on this panel. So proud to be a woman and empowered to get all my screenings and do all my due diligence. I'm here to talk about what is sex therapy and why you would want to see a sex therapist. I am Natasha Langhans. I have been licensed since 2008 as a marriage and family therapist. I'm originally from California, so I practice there and I'm licensed here and in California. 2 years ago, I started my journey being really curious about the sex field and getting a specialty in sex therapy. I'm currently in a PhD program. And yes, you can get your PhD in sex. So that's, yeah, I'm in my second year working on my dissertation and I just love what I do. So what is a sex therapist? It's a licensed professional that has been specially trained in sex, in sex challenges, in sexuality, in hormones, and in sexual health. Let's see, sorry. In sex therapy, I help people identify and work through sexual challenges such as low sex drive, pain during sex, religious trauma that has affected you throughout your life, difficulty having orgasms, and sex difficulty after injury or illness. There's so many reasons why people come in for sex therapy. I just help you improve your overall sexual satisfaction. So why would you need a sex therapist? If you are looking to have a conversation that's non-judgmental and safe with like a trained professional. So many issues that we talk about, including intimacy, cancer and sex, body image, menopause, sex and aging, sexual trauma, or any other challenges with your current sex life. So what are the most common reasons why people come into sex therapy, you might be wondering? The thing that I see most often is sexual discrepancy, desire discrepancy, which is one partner would like more sex than the other partner. So I would see a couple for that and discuss like what's getting in the way. And there could be a multitude of reasons. So we do a very thorough sex history for both partners and discuss, you know, what are parts of your history that could be getting in the way of desire. I just help clients to feel great exactly where they're at. A few sex therapy tips that I find helpful for clients during the different seasons of their lives. One is the difference between automatic and responsive desire. So when we are younger, or what we see in movies is this automatic sexual desire that you just see someone and you're automatically turned on and you want to have sex. But that is not most people's reality. And so educating clients, educating each other on responsive desire and what that actually looks like. And what that looks like is being in a situation where you're open to pleasure and you're open to connection. And so that's the more of a realistic reality of desire. And if you want to desire your partner, you already have desire. So many women come in confused. I don't feel like having sex. I'm not sure if I'm normal. And you are normal. You just have to kind of navigate what's getting in the way of where you particularly want to be. Another important fact that everyone should be aware of is that only 20 to 30% of women reach orgasm through penetration. And I think this is something that we don't talk about enough, and something that, you know, you can talk to a sex therapist about or do research on your own. It's common that women are confused and they think, well, there's something wrong with me. There's absolutely nothing wrong with you. And so learning more about your own body and being able to communicate that with your partner is key. There's just so much that to learn and discuss in this field, and I'm absolutely loving it. I love working with clients. If you're interested in working with me, or I can help you find a sex therapist, my office is actually located in this building. Yeah, so thank you guys all for being here, and yeah, let us know if you have any questions.
Thank you, ladies, very much for your talks and talks about aging gracefully. And one of the reasons that we brought Natasha in here is that if you don't know, most breast cancer patients, most patients with breast cancer are placed on a hormone blocker, and that blocks your body's production of estrogen. And not only the stress of having breast cancer, but the stress of all of the things that go along with not having estrogen and relationships. And so we really appreciate just the opportunity to have you here. So we're going to do questions and answers again. So here go the hands. All right, we'll go back here first. Whoops, I'm going to go to the back.
So I had a hysterectomy, oophorectomy earlier, in my late 20s. So something I struggle with, I mean, the hot flashes, all of that, but the desire part of my life, the desire to engage in, you know, sex and things of that nature. Is there like a magic pill that you can take, or is that, I mean, does that ever come back around, or is that just part of the process?
It's kind of a question for both of us, probably, because it's complicated. It's not just one thing. There is a very hormonal chemical aspect to sex and interest in sex. And, you know, that's something I talk to patients about who are maybe on birth control pills, and that suppresses your ovaries from ovulating, or if your ovaries have been removed and you go through early menopause because of that. To some degree, our brains tell us that we want to have sex because they're trying to trick us into getting pregnant, and we've released an egg and like, this is the time. And if you don't do that anymore, sometimes you don't get that like spontaneous chemical signal. That's another thing where for some people, hormone replacement therapy can be really helpful. It's not true for everybody. And, you know, I think I briefly mentioned testosterone not having a really obvious place in hormone replacement therapy for women. The little bit of data that does show that there is some benefit is in spontaneous sexual desire, though. So that's maybe something to talk to your doctor about. There's probably not a magic, but there are some medications that exist to help with, you know, low sexual desire. One is a daily pill you take, and I think it's a very safe pill. I think in the clinical trials, they found that people had 2.5 additional satisfying encounters a month. I don't really know what half means, if it's half an encounter or half satisfying. But I've had a couple patients take it and feel like they had really good results. There's also a medication that's a little injector, and you give yourself like a little shot with a pen, and it creates a sexual desire for 4 hours. I've had a couple patients feel like that was successful too. But I think you make a good point. Like if you're even kind of wanting to be interested, that's the first step. Do you have any?
Yeah. Well, thank you for asking. I think that as women, we have so many responsibilities, and we just put our desires on the back burner. And so you absolutely deserve to have the sex life that you want, the intimacy that you want. And it might look different than it did in the past, and that's okay. And so as you know, as if we work together, we would definitely do all the medical, like, you know, refer to a doctor and rule out all the medical things. Those things can definitely help. And then we would discuss like things that are getting in the way, whether it is your view of self, your view of your body, the way you view yourself as a woman, and go from there, and just get some realistic goals to where you want to be.
Okay, thank you, ladies. Another question from somebody? I'm going to go this way. Here you go.
How long can you take hormone replacement therapy? Like to what age?
That really, if you read the book as a little baby medical student, what they say is to take the hormones for 3 years and then pause and see how you feel. about half of women, whether you cold turkey stop your medication or you wean off of it, are going to have hot flashes again. Really, the key to the safety, if you don't have other risk factors of hormone replacement therapy, is starting it around that transition. So if you're one of those people who you try to stop taking your medicine and like 5 years later, you're immediately back to that terrible place you were before, you just keep taking it. I have a pretty low threshold for letting people continue their medication. It really depends on your symptoms.
And another question, I came to this side. Here we go.
Does dietary or oral collagen help your skin?
Not really. But if it makes you feel good, you can do it.
Another question.
Okay, my question is for Bajaj and Dr. Parker. So I'm a little curious because the older I get, the more I notice like I have this kind of acne around my bottom like jawline and stuff. And I know that Bajaj, you were talking about the medical grade like skincare and stuff like that. But for us broke girlies that don't really have a lot of money and we're struggling, you know, teenagers, you know, she takes all my money. So I'm curious, like, what would be a good alternative if you cannot afford the super expensive? I'm assuming it's really expensive, which I know it'd be worth it, but like I said,
it's somewhat expensive. I mean, we do specials all the time, and it lasts a long time. But then I would do the basics of good skincare, right? Cleansing, hydration, and moisturizing, and sunblock. Those are the fundamentals that you should do, and you should cleanse your face twice a day. I mean, how many times do we all just go to bed without washing our makeup off?
Sometimes.
All the time. I mean, sometimes. The other thing is the other trick is don't use hot water because that's going to increase oil production.
Okay.
Don't use hot water. It's going to increase your oil production.
I thought it was supposed to like open your pores and like get all the junk out. Like, that's all just bullshit? Like, okay, got it. Thank you.
Okay, we'll do one more.
So I'm seeing a lot, especially on social media, about baby Botox, and you should start getting Botox in your early 20s. And is there any?
So the idea behind the preventative Botox is that you start early so you don't develop those deep set wrinkles that are ironed in that you can't get out. I mean, you can do it. It's totally up to you because you have to remember Botox only lasts 3 to 6 months. So are you ready to start it in your 20s? I don't know if you can afford it in your 20s either. I mean, I don't know. I started in my 30s, but I had access to free Botox all the time, right? The thing is once you're 60 or 70 and you want to get Botox, by that time your skin has lost enough collagen and elasticity. Those wrinkles aren't going to go away. They'll get softened with the absence of movement, but they're not going to go away.
Okay. Oh, sorry. Go ahead. No, go ahead.
I was just going to ask a question about menopause. I ask you questions all the time. But so if you're having symptoms of menopause and we're going, oh, okay, I'm having hot flashes or my periods are getting irregular, is there a test? Do we just like take a test and go,
really good
oh,
question.
good, check mark, I have like strep or something, you know, is there a menopause test?
There are people who will test your hormones, and a lot of them will charge you cash for their special test. And you do get some information. You know, the thing is, hormones, like the female hormones, fluctuate so much even throughout the day. If we check it first thing in the morning and then later that day, you're going to get a different number. So it's a little bit hard to interpret what that means. And then once you've been through menopause and you're not having periods anymore, I already know that your estrogen levels are going to be really low and your progesterone levels are going to be really low. It's a hallmark of menopause. So there are tests. They don't really help us decide how to take care of you. If you had a question, like there is a test also called the anti-Mullerian hormone, AMH, and it's sort of a rough estimation of ovarian reserve, like how many eggs we may have left, like how much life is left in our ovary, but it hasn't really panned out to be as helpful for treating people as we hoped it would.
So follow-up question on the symptoms, and if you're having other symptoms, are you, like with breast implant illness is a common topic right now. Is that on the agenda? Are we going to even talk about that?
That is not on the agenda. We're going to have another one.
Yeah.
Okay, ladies, we're going to take another break. So you should have an evaluation form for session number 2. Same thing. If you'll fill it out and turn it in the back, we'll have a name drawing for another basket, and we'll take a 10-minute break. And there's some chicken nuggets over there now, too.
And I just wanted to say there is a thing for discounted skincare in your bag.
Oh, perfect. Grab one.
If you're having, like a simple illness and then you're having like fatigue and fog,
Yes, let's go see. In the back. She has them in the back, it looks like.
and then we just blow it off because I wanted to think it might be just an illness, and it's just not. One lady, I think she's in there last week, now was upset because she liked her before. Yep, and now they're like, well, now I don't like my body. I can't believe it's not on the agenda. Free. Hi, Connie. It's fun. You got all the laughs. It's good. Or you were back on schedule. Are we? Yeah. Good. I think I was close to it. One of the ladies who came up to she got all the laughs. I love it. Oh, she was here. Yes, yes. She's here somewhere. She's at the back. She's at the back in the line. She's the jeans and the sparkly. Oh, yeah. She's the one with the blonde. No, she's the one from the tornado in 1999. We drove it right there in the white shirt. Yes, yes. So long-term use toxins can
Juvo. And I swear I didn't get 3 weeks of it. I don't like Juvo. Maybe it was when the anesthesia providers was anyway, so I don't know if it makes a difference which one you use.
You can't develop antibody resistance. The underfed is also toasted. So a lot of times when we're trying to skin, they underdose, and that's how we So if you're dosing, antibody resistant, and it could be used to different things.
The other question I have is not related to that. Is your dad still around?
Yes.
Because I used to work with him when he was working with Ed Show. I worked with Ed growing up when I was like his MA in the 80s, and while I was going to yeah, I figured, but I love him so much. And I see Ed every once in a while, but he still goes for it. Anyway, I always wanted to ask you that because I just dearly love your dad. He was so sweet. And I used to work in the OR at Mercy also. He would come in and help. So, but thanks for your time. I appreciate it.
Yeah, you use less. Yeah, and then you don't have to have all of them. That's what I think. You don't have to have all of them. That's, I think, where people get confused too, because there's so many. Yeah. There's cereal, this, this, this. You don't have to. Yeah. Just, I don't have enough room on my face. There's so many. Kids so good and it takes 3 hours to get it. Yeah, everybody loves the crumble cookies. I get them sometimes. Yesterday, somebody brought mug cakes, nothing but, yeah. Well, that's little ones. Yeah, that's you get a lot of crumble cookies.
Hey, ladies, did everybody turn in their session 2 evaluation forms? Anybody else want to be in the drawing? Did you turn it in? Are you going to draw for us? So, here's the
This is the second one.
That's the one we just did.
That happens when I walk by it. I'm sorry. Make it.
Okay, so our final session.
Yeah, so you'll just
Our final session is going to be started by Dr. Ariel Allen. She's going to talk about pelvic floor prolapse. Our next speaker will be Sherry Bose. She's going to talk about pelvic floor treatments and therapy. She's going to come hang up here. And then Dr. Jessica Enix is going to talk about anal rectal health. So, so we're going to draw again. Dr. Allen, you want to draw for us? This is for another gift basket.
Ann C. Ann? Is Ann in the... Ann C. Okay. Congratulations. You getting all your stuff? I am. So nice. You got props. All right. Are we ready? Okay. So to introduce myself again, I'm Dr. Ariel Allen. I am can you hear me okay? I'm a fellowship trained urogynecologist. And so what that means is I do a little bit of gynecology, a little bit of urology, but I don't do all of gynecology or all of urology. Urogynecology is a specialty that focuses on the female pelvic floor. And so that means I do not do well woman exams. I leave all those to my colleague, Dr. Lacey Parker. But I also don't take care of urologic things such as kidney stones or things like that. I leave those to my colleagues that are urologists. So urogynecology is truly treatment of the female pelvic floor and pelvic floor disorders. 2 of the most common things that I see are pelvic organ prolapse and urinary incontinence. Due to time constraints, I'm actually going to talk about just urinary incontinence today. But if you guys have questions about prolapse, I'd be happy to take them later. Okay. All right. So to get going, am I good? Okay. To get going, female urinary incontinence is what we're going to talk about today. Let's see. Okay. The prevalence of bothersome urinary incontinence. The key word is bothersome. I know that sounds weird because you're like, urinary incontinence, isn't that always bothersome? You'd think it would be, but there's actually the majority of women, especially if you've had babies, are going to have some form of urinary incontinence. Like it's nearly 100% of us. But not all of us are bothered by it because it can be very, very mild. Doesn't really affect our quality of life. But the prevalence of bothersome urinary incontinence, where it does affect our quality of life, is very high. And the highest incidence, or the age at which it's the highest is age 50. And it gets up to 80%. So it's very, very common. Let's see. All right. There are actually 7 different types of urinary incontinence a woman can have. I'm going to talk about 3 of them. They are the 3 most common. There's urge incontinence, stress incontinence, and then mixed. And I'll talk about all 3 of those during this talk. Urinary incontinence, as defined by one of our societies in my specialty, the International Continence Society, the ICS, it's defined as the complaint of any involuntary leakage of urine. So when you're not wanting urine to come out, it comes out. And then 2 out of 3 women suffer from urinary incontinence on average. Okay, so urge urinary incontinence. The ICS defines it as the complaint of involuntary leakage of urine accompanied by or immediately preceded by the feeling of urgency. It's the gotta go, gotta go. You feel like you have to go to the bathroom, all of a sudden your bladder starts to leak before you can get to the bathroom. And you're like, well, I knew I had to go, but I didn't know I had to go that bad. That's urge incontinence. The common symptoms, like I was just saying, is leakage associated with the feeling of urgency. It's that gotta go feeling. Women will complain of urgency. They'll complain of frequency, like feeling like you have to go to the bathroom all the time. Like, I just went to the bathroom 30 minutes ago. Why do I need to go again? These symptoms can be triggered by certain cues, such as hearing or seeing running water. You walk into a beautiful lobby and there's a beautiful fountain and you're like, well, that's not fair because I need to pee all of a sudden. Where's the bathroom? The sight of a bathroom even, you're walking down the mall and you see a sign for a restroom. You're like, oh gosh, all of a sudden I have to pee. Why do I have to pee all of a sudden? I didn't have to 2 seconds ago before I saw that sign. That can be a sign of urge incontinence. Keyhole incontinence, or another way of describing that, is called door key incontinence. And that is also super common. And it's when you're driving home and all of a sudden you see your driveway and your bladder's telling you need to go to the bathroom. You're like, oh my gosh, I just left work. I didn't know I had to go to the bathroom. I didn't even feel like I had a full bladder. I see my driveway. I'm driving into my garage and I have to go now. That is door key or keyhole incontinence. It was named because you put your key into the door because you're coming home. You put your key into the door to unlock it, and that's when all of a sudden you have to go to the bathroom. Nocturia is defined by going to the bathroom more than 2 times a night. It's actually considered normal. I don't know who decided this was normal, but 1 to 2 times a night is considered normal. None of us like to get up to go in the middle of the night. I think a man probably just defined that, but it's 1 to 2. I'm sorry for the men in the room. 1 to 2 times a night is considered normal. Getting up more than 2 times a night is nocturia, or the definition of nocturia, and that's considered abnormal and can be a sign of urge incontinence. And then bathroom mapping. I hear this every day of my practice. Bathroom mapping. Does anybody know what that means? I bet you. That's right. Yes. If I had a gift, I'd give it to you. Everywhere you go, you know where all the bathrooms are. That's bathroom mapping, and it's an absolute sign of urge incontinence. Okay. Yep. Or if you're afraid to go somewhere because you're not sure where the bathrooms are. If it's a new location, you're like, I don't know if there's enough bathrooms. Thank you, Pooja. You're afraid to go places because you don't know where the bathrooms are. That's also a sign of overactive bladder or urge incontinence and is bathroom mapping. So what are the risk factors? Who gets urge incontinence? There's a lot of different risk factors. The number 1 is age and being a woman. So we all pretty much get this at some point in life. Bladder irritants can lead to urge incontinence. The most common ones are smoking and caffeine. Prolapse, pelvic organ prolapse, again, is not something I'm going to talk about during this talk, but it is also super common and can lead to urge incontinence. And prolapse, is where the bladder falls. You may have all heard of a bladder falling, and that is a form of prolapse and can lead to urge incontinence. Diabetes, 80% of all diabetics, whether type 1 or type 2, will get urge incontinence. So I see a lot of diabetics in my office. And then any form of nervous system abnormality can lead to this as well, because what causes urge incontinence a lot of times is an abnormality of the nerves that innervate the bladder, are responsible for bladder function. And so almost any kind of nervous system abnormality can lead to urge incontinence. Okay, so moving on to stress incontinence. The ICS defines stress incontinence as the complaint of involuntary leakage of urine on effort or exertion, such as with sneezing or coughing. So I will always ask my patients, do you leak urine when you cough, laugh, or sneeze? Those three. And so if you leak urine when you do those things, that is stress urinary incontinence. The symptoms, like I was just saying, is leakage when you cough, laugh, or sneeze. The risk factors for this are actually younger age. So this tends to be a younger woman's type of incontinence, but that's a terrible thing to think, because a lot of women get stress incontinence no matter what age, and a lot of women urge incontinence no matter what age. Another risk factor, though, is having more vaginal deliveries. In fact, if you've had 2 or more vaginal deliveries, you're 8 times more likely to have stress incontinence than someone who's had less than 2 baby vaginal births. And also large babies or more difficult deliveries will increase your risk for this happening as well. An increase in BMI or a higher weight can lead to stress incontinence. Chronically increased abdominal pressure, meaning chronic constipation or chronic straining or pushing to have bowel movements, and a chronic cough, so if you've got COPD or asthma. And then mixed incontinence is kind of what you think it would be. It's when one woman has both urge incontinence and stress incontinence. Again, that's not fair to have 2 types, but it's mixed. The ICS defines it as the complaint of involuntary leakage of urine associated with urgency and also with coughing, laughing, or sneezing. It's a combination of the 2. So when coming to my office with complaints of urinary incontinence, you will get an initial evaluation. I will ask you all of your symptoms. I will do a physical exam, and I will check your urine and make sure you don't have a UTI. That sounds so basic, but a lot of times women will come in complaining of these urgency and frequency symptoms, and I check their urine and see UTI. So easy fix is an antibiotic. To talk a little bit about initial treatments for incontinence. Lifestyle changes, we talk about that a lot. If you're a smoker, I'm going to ask you to stop smoking. And there's a lot of good reasons to stop smoking, but in my world, for your bladder, restrict the caffeine. Oh man, those energy drinks that are so popular, they are causing even girls in their teenage years and early 20s to have urge incontinence. It's because they're drinking those Red Bulls all day long. And then weight reduction, of course, decreasing the intra-abdominal pressure will decrease your leakage. Pelvic floor muscle therapy, I'm just going to touch on this because my colleague here, Sherry, is going to talk about pelvic floor physical therapy in just a little bit in more detail. There is great data to support the benefits of pelvic floor physical therapy for the treatment of most types of incontinence, especially these types, okay? Talking about weight reduction, there was a great study done back in 2005 that showed that just a 10 to 20% weight reduction decreased incontinence episodes by 50%, okay? So it really does help to lose weight. Additional treatments, there are non-surgical and surgical treatments for stress incontinence. There's something called an incontinence pessary, which is a device that you wear in the vagina. I know that sounds weird, that something like that would help the bladder, but they are right next to each other. A pessary is shaped in such a way that it creates a little bit of obstruction at the level of the urethra or the outlet of the bladder to reduce the ability of urine to leak out. That's simply how it works. They do not hurt. They don't cause infections. They're a great non-surgical option. And then there is a vaginal laser treatment that we do in the office. It's also non-surgical. And it changes the muscle and the nerves that control the bladder, basically, and improves incontinence. And of course, there are surgical options for stress incontinence, urethral bulking, a urethral sling. I can talk about those in more detail. Treatments for urge incontinence. Medications are always first line. There are a lot of different medicines out there to reduce urgency and frequency. They have about a 60 to 80% success rate. There are some side effects, but they are always the first line treatment. There's something called PTNS, or posterior tibial nerve stimulation. I'm sorry I'm going through these quickly, but I'm running out of time. PTNS, posterior tibial nerve stimulation, is an in-office treatment, does not hurt, has an 80% success rate in the reduction of urgency and frequency, And the vaginal laser is also a treatment for this. There are surgical options, Botox. We heard about Botox from Dr. Bajaj, but there's Botox for the bladder as well. Has a 90% success rate, lasts about 6 to 12 months in the bladder. It can be done in the office or in the operating room. And then there's an actual implant for the bladder for urge incontinence that is done surgically. I call it the pacemaker for the bladder because it's very similar. It affects the way the nerves run to the bladder and improves incontinence, urge incontinence. And then, of course, when I have patients that have mixed, that have both of these, I always ask them which one bothers you the worst because that's the one we're going to treat first and then get that treated and move on to the other one. So, and that is what we're supposed to do, is treat the predominant symptom first. So if you're more bothered by urge incontinence, I'm going to focus on that, get that treated, and then move on to the stress. All right, and we'll take questions later, but that's the end of my talk. Okay, I hope y'all learned something.
I think I do want to walk around actually. And I just want to say I love how all this is kind of intertwined and overlapping because everything that she just got to telling you, I'm going to hopefully bring it together because, using exercise. And I know all of you guys that know me know I'm an exercise fanatic. So, I got my weights. Just got to tell you, for the vaginal or the pelvic floor. So, first of all, I want to tell you that I've been treating incontinence and pelvic floor dysfunction for 28 years. Started at OU Medical Center and then opened a lot of different clinics. Now I own my own clinic in Yukon. But I want to give you, first of all, 3 important things to take away today that will that you can use without needing me. If you need me, I'm here, but I wanted to give you something that you could actually use, take away, use at home, and then if you need me, come see me. But hopefully you won't. First of all, the 3 things are vaginal weights, quick flicks, and intercourse. And before I get into that, I want to talk to you a little bit about the anatomy of the pelvic floor. The pelvic floor is a hammock. Sorry, I'm moving my microphone. A hammock that surrounds the vagina, the urethra, and the rectum. There's 4 specific muscles. They're really long, so I'm not even going to tell you what they are. But those are your primary pelvic floor muscles that keep your internal organs separated and in place. Then you have accessory muscles. Accessory muscles are the ones that just come along for the ride. And they are your abs, your adductors, and your glutes. You can use those, and I'm going to tell you when to use those, but you really want to isolate those 4 muscles. And a lot of women have trouble with this, and that's why I have my job. Because those muscles, a lot of women never learn how to identify them. And sometimes never. There are women out there who never have an orgasm, if you can believe that. And it's usually because they never identify their pelvic floor. The youngest patient I've ever had was 16. The oldest patient I've ever had, 98. And it's all to teach them how to use their pelvic floor. So how do I do that? First, I have to do an internal exam. There are 5 levels. 0 is nothing. You can't do a thing. 5 is you don't need me because you're so strong, you know where it's at, and I don't know why you're here. Which is never anybody. Ever, 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 ever. So one thing I'm going to have you do right now is I'm going to and it's not to get on anybody. I just want to see if you can identify the muscles. I want you to put your hand just on your abs. Nothing else, just your abs. And then I'm going to ask you to squeeze your pelvic floor. See, nobody else can see you do this but you. Nobody else can feel you do it but you. And now I want you to relax. And then I'm going to have you do 3 quick flicks. Okay. If anybody felt their abs contract at all, that was an accessory muscle. You're not supposed to use those unless you're having intercourse. You bring everything to the room for intercourse. Everything. So, that's how you identify those muscles. So yeah, you can laugh. I've got my weights here. I'm gonna let you feel these. Don't take them home because these are mine. Not used, but mine. So this one is the lightest one. This one is the heaviest one. Most women can start out with number 1 or number 2. The important takeaway here too, not only with these vaginal weights, is we've got to use these muscles functionally. Laughing, or it will help with laughing, coughing, sneezing, okay? But we need to do them lying, sitting, and standing, walking, talking to a friend, washing dishes. Put this baby in and walk around the house without your clothes. I mean, loose clothes, because it might fall out. So I'm going to pass these around because I really want you to feel how heavy they are. This one's the lightest. You should probably start with this one. If you can brush your teeth, walk around the bathroom, put on your makeup, do some dishes, fold some laundry, things like that. You will, and hold that in and build from 5 minutes to 15 minutes. Your pelvic floor is going to be so toned, and you're going to know where it's at. If it pushes out, you're pushing down. So you have to pull up and in to get that muscle, okay? So she's already talked to you about stress incontinence, urge incontinence, and mixed incontinence. So this is where I come in. She's identified it. I usually do a question, and identify it too, but then I have to figure out how to treat it, okay? So the first thing I do once I decide how weak your muscles are, then I decide what device I'm going to use. This is a biofeedback unit. This is a vaginal probe. The vaginal probe has electrical stimulators right here on it, or electrodes that will stimulate or give me a number with the pelvic floor contraction, okay? Then it's hooked up to a biofeedback unit. I can set my threshold very low. If you're a 1 or a 2, which most women are after childbirth, then I'll set my parameters down really low so that you can achieve something. If I set them up too high, you're never coming back. But if I set it down low to where you can see that your muscles are working, then every time you come in, I make it a little higher, make it a little higher. It's kind of like playing limbo, but the other way. So that's biofeedback. If I don't feel a contraction and you're a 0, I have another unit called an electrical stimulation unit using the exact same probe that I place vaginally, and it stimulates the muscles. So it jump starts it. So it gets you stronger and going, okay, I know what that is. I know what that is. Then I can go to this, and then I can go to the weights. 3 to 5 visits max, you're done. You don't need me. And that's the way it should be. Yes, I'm here for a lifetime, but you don't need me for a lifetime. I just need to teach you what you need to do. So the next time when you laugh, cough, and sneeze, you can actually pull that pelvic floor up and not push out any urine or gas or anything else. The other, yeah, I know. So same thing. The tools are the same for urge incontinence, except I don't need to use biofeedback. I usually go straight to the E-stim. The E-stim, there's a muscle in your bladder called the detrusor muscle, and that muscle tells you when you need to go. This relaxes that muscle. But what I told you a minute ago, very first initially, was quick flicks. So this is valued information. Quick flicks of your pelvic floor tell the detrusor muscle, calm down. I'm not near a bathroom and it's not time to go. It also allows you to build your bladder capacity for urge incontinence. So, and stay-at-home moms, and a lot of us work from home anymore. I don't have that privilege, but a lot of people do. And that's going to kind of serve people into urge incontinence because your bathroom is going to be right there and you're not going to have to do, use your muscles as much. So you're going to have to build your bladder capacity again. And then mixed incontinence is a little bit of both. The last thing I want to talk to you about, though, is pelvic floor pain. And her and I talked about that just a few minutes ago. Pelvic floor and pelvic floor dysfunction is a huge number of complications. And I'm just going to give you briefly just a couple. I treat women for all kinds of pelvic floor dysfunctions at an early age. Women who are preparing for marriage and they know they can't use a tampon. That's a problem. They'll seek me out. I'll do some dilators, and they're on their way. It usually not very many visits, but a lot of girls, they don't even know that that's available, and it is. And there's a lot of girls who are totally unable to use tampons. We start with dilators, and it's all a very relaxed environment, a lot like this. I try to make it as easy as possible to talk to anybody because I have a lot of intimate patients and different diagnoses. But and then also pelvic floor pain from either trauma or pelvic floor tightness, and I would use the biofeedback. I know you and I have talked about that. We would use the biofeedback, but in a reverse way. Instead of trying to get stronger, we try to get relaxed. So, and then there's other things like scar tissue, both vaginal and external scar tissue, episiotomy scars, dehisced scarring in the vaginal area. I have 2 patients right now with episiotomies that failed. And so we're treating them for that. Another thing is microscopic tears after any vaginal delivery, any vaginal hysterectomy. And then there's also women who are suffering from tissue inflammation from autoimmune diseases, and their medications and things like that cause tissue inflammation. So the takeaway, or the 3 things that I wanted to make sure I gave you, which were vaginal weights, don't forget, don't lose mine, quick flicks to give you time to get to the bathroom, okay? 3rd one, intercourse. We have to know where these muscles are for both our enjoyment and our spouses or significant others' enjoyment. The more you're aware of these pelvic floor muscles, the happier you're going to be. The orgasms are stronger, longer, better. Intercourse helps you with better pelvic floor health because you have to use those muscles. So it makes you stronger. Ask your husband, ask your spouse, can you feel me contracting my muscles? Because that's vital. If he can't, then make it a game. Tell me when you feel it, And I tell you, the more isolation you can get in this pelvic floor, the muscle group, the better control you're going to get in the bedroom. And I want to tell you one other thing, and that is that all intercourse does not need to be a marathon. It can be a sprint. It can be a half marathon. Sprints are just as good as the other, okay? They're all going to push the body parts back where they should be, and they're all going to strengthen your pelvic floor if you use it right. You never want to squeeze those muscles at the beginning. You want to wait for the finale, okay? You can squeeze it a little bit, but not too much. Wait for the finale. Okay, that is it. I hope that was helpful.
All right, so I am the last speaker. I'm Dr. Jessica Enix. I'm a board certified general surgeon. So that means I do a lot of different types of operations that include mostly the abdominal domain. However, I feel like I've had some fellowship training in normalizing some of the most sensitive areas of our body. And that involves the pelvic floor, but specifically in my area, it involves the anal canal. No one ever wants to talk about it. And so it's always my goal to make the environment safe, comfortable. It can feel funny, comedic sometimes, but what I need to know is that you can share anything with me. And that's also kind of what really got me interested in being part of planning this, is because our bodies do amazing, wonderful things, but our bodies also do body things that we should not be ashamed of, and we need to be able to talk about it if something is happening. So today I'll be talking about just common issues that involve our anal canal. And of course the perianal skin, because it is the most highly innervated tissue, the skin on your body. It is the most highly innervated part of your whole body. I am a surgeon, so I love to operate, but this is a quality of life issue. So I want to give my patients a lot of options that include medical treatments. And then I also want to touch on the fact that anal cancer is a big problem, and an anal cancer is related to not talking to your doctor about something that has changed and popped up in a location that you don't want anyone to see. And I don't want that to ever happen to anyone. So we're going to talk about some anatomy. This whole show is mostly just slides and videos because, again, it's normalizing what our bodies do. So as we've talked about in women, it's very, very packed down within our pelvis. You can see our bladder here, our uterus when we still have one, and then of course our rectum coming down into the anal canal. You can see this area is not very wide, and that area can be affected by any of the adjacent muscles. Now imagine what happens when that pelvis and that uterus becomes pregnant. And these are pressure lines to also kind of describe and show what happens, what direction the pressure gets pushed, and why pregnancy, even without a vaginal delivery, is the most common cause of hemorrhoids in women. Now, these are all those muscles that Sherry talked about. They do have tons of fancy names. Do not memorize those. But the whole point is that this is a sling and they all communicate. Urethra up here, vagina here, anus here. A problem in one, muscle spasm in one, will affect the others. So now this is a little talk about continence. I hope the video works. This is actually a video about what our body actually does in order to have a bowel movement. No one ever wants to talk about it, but it is an amazing thing that happens. So when we're at rest, our rectum has this shape that's almost like this S channel. Holds everything in place. We all have little tiny internal hemorrhoids that help us hold pressure to keep everything in at the right time. And then when we can go to the bathroom, let me see if, well, we may not have a video. I was hoping to be able to show you guys the video, but what ends up happening, this section here is the patient's rectum. These muscles drop down while the muscles along the back contract in order to straighten out this area, and then your anal sphincter relaxes in order for you to have a bowel movement. That is a lot of things that happen once a day, once every 2 days, once every 3 days. And it's something that we need to be sure and take care of. And if we're having a problem with it, we need to be sure and have it addressed. Now, this is the area that I'll be mostly focusing on, the anal canal, and it's right underneath that area of the S shape. So first we'll start with hemorrhoids. Like I mentioned, everyone is born with what we would call grade 1 internal hemorrhoids. It's just those little tiny vascular cushions that sit along, this is your sphincter muscle, that holds everything in. That way you can pass gas without a bowel movement and hold things in if you need to. But it is these things, almost just like varicose veins, that can get large, increase in size, and like if you can think of that picture with the pregnancy, the pressure pushing back into the pelvis engorges these vessels and can cause them to enlarge. And those are symptomatic hemorrhoids. Now, the other thing that I want to talk about is a fissure, because these things are easily treatable without surgery and can be hugely affected by the type of treatment that you undertake. So that's why I wanted to start with medical treatment first. Hemorrhoids and anal fissure treatments overlap, but there's one huge difference. You see me, you see Dr. Singal, I promise you we will talk to you about a fiber supplement. We will talk to you about GI regularity, staying well hydrated, and I also like to throw in the probiotic conversation. We want to have good toileting behavior. It's a pressure thing, so you can imagine your bottom sitting in a circle for prolonged periods of time. So we don't read, we don't take our phones to the bathroom. It's only for business. I am a huge fan of bidets. If I could be sponsored by Toto, the bidet company, I would love it. I have 2 in my home. It makes a huge difference. Granted, these can sometimes be in conflict because they can be very, very comfortable, but it really helps treat and take care of that tissue because it is sensitive. So if we don't want to do a bidet, let's get rid of the toilet paper. Consider things like Tux pads and wet wipes. Sitz baths, warm baths, and heat help with discomfort and symptoms as such. And then, this is so important, hemorrhoids and anal fissures improve with pelvic floor physical therapy. The thing is that muscle-mind connection. So you have something that is uncomfortable, you have an anal fissure especially, which is exceedingly painful, that causes spasming in the muscles, and it is just this terrible feedback loop that you can get into. And so you tense those muscles up, and then you perpetuate the problem. Now, this is where we take a big fork in the road. So most of you will see your primary care doctors when having these initial complaints. Hemorrhoids and anal fissures do all of the things above here. But hemorrhoids should be uncomfortable, they should burn, maybe fire-breathing dragon, but you will never have the sensation of a sharp razor blade coming out of your bottom. That is an anal fissure. So if you go to your doctor, you have that symptom, and they tell you they want to give you Proctofoam, you say no. No, no, no. Proctofoam has steroids in it, which is wonderful for hemorrhoids, but it is just a Band-Aid, right? So it thins the skin, and it actually decreases your ability to heal. So when we're talking about an anal fissure, that is the last thing that we want. So anal fissure is a split in the posterior aspect of the anal canal. It's very important to me because it is lower risk for me to operate on your hemorrhoids than it is for me to operate on your anal fissure. So unlike Dr. Allen, if you come into my clinic with both problems, I will try to fix your anal fissure first with medical intervention. This is the reason why. You may not be able to see the line, but the surgery for me to fix this for you, if all of my medical treatments fail, is I have to make an incision here, and this is a sphincter muscle. This is what controls your ability to hold in your bowel movements. I cut through that. So we have that conversation that if we get here, there is a risk of long-term stool incontinence. So this one gets fixed first. So what I want everyone to take away and also be able to talk about with their loved ones and their girlfriends, if you have an anal fissure, do not put steroids on it. An anal fissure with steroids on it will never, ever heal. No Proctofoam, no Preparation H, nothing like that. And this is actually exactly what it looks like in the operating room. An incision right here, and then just a knife blade through the muscle. It's terrifying, honestly, for me. Most of the time, the results are very, very good. But we hate getting there. Now, surgery for hemorrhoids. We can talk about that all day. I offer lots of different options. Treatment for hemorrhoids is mostly geared towards quality of life. So if you have hemorrhoids that are causing bleeding, itching, discomfort, we can talk about trying all of our medical options. If we exhaust those, we can do surgery. This is a procedure that I like to call hemorrhoid light. Makes hemorrhoids smaller, but doesn't make them go away. This one actually removes the internal hemorrhoids without removing the externals. The thing that's nice about internal hemorrhoid treatment is it's easier to recover from and less pain because I am staying above the innervated part of the anal canal that we talked about has all of those hundreds of innervation tips. And then this is a traditional hemorrhoidectomy. I perform these as well. This allows me to remove both the internal and the external. Externals are quite painful though, and it has to be worth the recovery time to undergo the surgery. Now, I did want to touch on this, like Dr. Parker talked about in the beginning of the symposium about cervical dysplasia. Now, the same virus affects the anal canal, HPV. The most common types that we see will actually cause anal condyloma. Anal condyloma can be easily treated with chemical treatments or removal. I offer multiple different options in the clinic as well as in the operating room to be treated. However, this is the thing that I want everyone to be able to talk about. Because if someone has something on their bottom and doesn't have it looked at and it grows, it can become anal cancer. And I don't have a picture of her, but Farrah Fawcett died of HPV-related anal cancer. And this is something that we can prevent. We know that it's associated with HPV 16 and 18, but we also know that it's associated with almost 91% of all anal cancers have some form of HPV. So it's very important that if you've ever had an abnormal pap smear, that you pay attention to your body, look at your pelvic floor, and if you have any questions at all, have a rectal exam. Have someone you trust go in and see your doctor. And I am a huge fan of Gardasil. Gardasil makes a huge difference, decreases your risk of HPV-related cancers. So something that I do offer in my higher risk patients is I am actually doing what are called anal pap smears. Now this is for patients that we know have not cleared HPV higher risk strains. This is also for people that participate in anal receptive sex. And then of course anyone in the homosexual population that has multiple different partners. And this actually looks a whole lot just like your pap smear whenever you go into your doctor's office. So I just wanted to hit home that our bodies are strong, they are complicated, and we just need to be able to talk about it when anything is going on. Thank you.
Okay, ladies, any questions for this panel?
Asking for a friend. For fecal incontinence, I know some people have that problem. Do they have, like she passed around the vaginal weights, do they have anal weights that help somebody with that?
So we don't have anal weights, but fecal incontinence can be drastically improved with pelvic floor physical therapy. Again, it has to do with that mind-muscle connection. But it is a quite difficult thing to address. Now, I do get that referral. Sometimes it can be caused by other things that I can address surgically, but if it is a true fecal incontinence issue, I have a very wonderful colleague, Dr. Christina Booth, that's a colorectal surgeon, that is great at treating this. That video I was trying to show was actually, it's called an MRI defecography. And it specifically looks at the muscle function involved in someone that may have stool incontinence.
Other questions? Yes.
So there is a whole process. This isn't something, because further studies do need to be done to prove that it is actually effective. I offer it because I take care of a lot of high-risk patients and I take care of a lot of condylomas in my clinic, but I did have to design a process in which my pap smear goes through my pathology lab and then goes off to the DLO. And then that way, if I get an abnormal, I take them to the operating room where I do something called high-resolution anoscopy if I don't see a lesion. And then I biopsy areas, and then we compare the pap to the biopsy. So hopefully in the future, we'll have something that's more translatable.
Who are doing anal pap smear in Oklahoma. Is that correct? Because it's been so hard to find somebody who does it. So especially in HIV population and immunocompromised patients. So refer to you because you're working on that process and have.
Any other questions?
Yeah, I'll come back there next. Yeah, go ahead. I have a question for Sherry on the weights. Is that something that you can just start on your own, or would you need to be seen by you first?
That is a great question. You can start it on your own. You can, I've ordered them on 2 places, Amazon, just at $50, eBay, $20 to $30, and they last for a lifetime. That's a really good question. So I would say don't just Google vaginal weights and you'll get the intimate rows. And believe me, we've tried them. We've tried them all. So these are the best because they're silicone. You felt the gripping about them. You can actually grip. Don't use any KY jelly or anything. You don't need any of that. But anyway, yeah, the intimate rows, intimate rows. Google it first. It'll take you to the intimate rows. Then go to Amazon or eBay and put in that. Intimate rows, ROSE, and then put in vaginal weights. Okay.
Okay.
My question is about the Gardasil vaccination. What's the recommended age range for people to receive that? I mean, I know they give it pretty young, the pediatrician will, but what's like?
So my slide has it, you can get it between 9 and 45. So there's a large age range there. We know that if you get it while in your teenage years, you should only get 2 rounds of it. Gardasil 9. So let's say Dr. Parker had mentioned the vaccine came out when we were in college or med school. That's what it was. We were in med school, and I believe it was Gardasil 4 at the time, and now it's like up to like 9 to 12. And that treats more ranges of the HPV virus itself. Now, when we're older and we get the Gardasil vaccine, the recommendation is to do 3 rounds. And it all has to do with how our immune systems have developed. So 2 vaccines because our immune systems are so active when we're young. Usually adequately vaccinates us. As an adult, you will need 3. Even if you have contracted a high-risk strain or have been diagnosed with a strain of HPV from condyloma or from an abnormal pap smear, getting the Gardasil vaccine will still help your immune system to attempt to clear the virus or to also make sure that you don't contract any additional viruses.
Okay, you have another question? What if you are over 45?
Well, the FDA hasn't come out with recommendations. I will say, so this is something that is very unique about many of the physicians and providers that we have here, is that we're in private practice. And so also having the ability to have that conversation and say, well, we can attempt to submit this through your insurance and see if we can get approval. When we get outside these ranges, it does get more difficult to get it covered. I, just because I do so much colon cancer screening as well, have a tendency to say, we need to prevent, reduce, and treat in healthy patients no matter what their age. And we know that patients over 45, and especially those patients over 70 that have lost a partner and are back in the dating field, is the highest growing rate of sexually transmitted diseases, which would also include HPV.
Well, you can ask a question.
Can you just touch again on what you said between the hemorrhoids and the anal fissure? Like, what are you looking for the difference? Like, what symptomatic differences between those two, so you know which one you're dealing with and where you need to go see somebody about it?
So the biggest symptom is going to be the pain difference because it can get really tricky. The thing that anal fissures do to us that is the worst thing that makes it so confusing is something called a sentinel pile can be created. And what that means is that that area has split open right along your sphincter muscle. And we've had enough trauma either from pelvic floor spasm, from constipated bowel movements, that it just keeps getting re-traumatized and it develops this lump of scar tissue. That lump of scar tissue can get mistaken for a hemorrhoid. And I see it more often than I'd like to. So the big difference is the pain. Pain with a bowel movement that feels like razor blades coming out of your bottom should not occur with hemorrhoids. Hemorrhoids will burn, they will cause pressure, they are uncomfortable. Sometimes you feel like you're sitting on rocks, but it is not razor blades coming out of your bottom. And that is the big, huge difference. A good exam will also outline that. However, someone with an anal fissure, you should never do a rectal exam on. Like we talked about, all of these muscles communicate. So all I simply have to do if I suspect it in clinic is I press those muscles right along the edge of the anal sphincter and it immediately sets off pain. Hemorrhoids don't do that.
Hemorrhoids don't do that. Ladies, thank you all for coming today. We're all super happy that we got to do this. We absolutely plan to do it again. We want to thank each one of the physicians and the other speakers who came. I think it was really important. I think we're super empowering women is what we really want to do. You should have resources to everybody who spoke in your bag, but if you need anything at all, you can call up here. We have cards and different information.
Wanted to tell everybody that we have what Power is all about up over there with our core mission statement and core values, if anybody wants to take this. And then we have this sheet. If you want more information regarding our future projects, please sign up on this sheet of paper.
Thank you all for taking the time to come out and spend your Saturday morning with us.
All right. And if anyone wants to take any pictures, we've got stuff in the back that you can take pictures with, and we can post to social media.
I've recorded Does anybody specifically not want to be seen? Let me blank your face out. Most of your faces aren't on it. It's mostly just them. Okay.
Happy Mother's Day to everybody.
Our video person. That's good. I wondered about that. Very good. Hold on. All right.
You take a picture, let's see yourself. Take a picture, let's go.
Yeah.
Oh, okay.
Come on, ladies. Let's all surround. Sorry, I didn't even see you. Come.
Hey, Kristen, take your head over here. Okay.
These were